Welcome to More Health, Less Healthcare. I'm Peter Boland. This episode of What If They Got the Incentives Right focuses on food as medicine because the results are so compelling that we can't afford not to embrace it as a mainstay of clinical service. So I call this food as medicine, and the numbers don't lie. Now let's start with the number 80%. 80% is the reduction in the healthcare costs for type 2 diabetes patients at the Geisinger Fresh Food Pharmacy program. The actual cost per member went from $240,000 down to $48,000 per member. And the clinical outcomes, case reporting describes an average reduction of 1 to 2 points in HbA1c, which translates directly to decreased risk of death and serious complications, alongside improvements in BMI, blood pressure, and LDL cholesterol. Most patients also lost between 10 and 50 pounds. Now ask yourself, what's the last time a drug achieved those kind of results? And when's the last time any clinical intervention in your network moved those numbers? The intervention was food, medically tailored, consistently provided, culturally appropriate food, not a prescription, not a surgery, and not an expensive specialty drug, just food. Now, the episode makes sense, and the numbers make it easy. That food is a clinical asset, not just a charity program, not a community benefit line item. It's a clinical asset with a documented return on investment that should be embarrassing to the rest of the industry. So let's look at the Geisinger Fresh Food Pharmacy, the diabetes case. Geisinger Health Plan is in Danville, Pennsylvania. Started from an honest question. Why, despite all the clinical resources they were deploying, were they making so little progress on type 2 diabetes? The answer was sitting in social determinants data the whole time. Patients couldn't manage disease that's fundamentally diet-related when they didn't have consistent access to healthy food. And the Fresh Food Pharmacy program addressed that directly. Patients with type 2 diabetes received monthly medically appropriate food, enough to prepare 10 nutritious meals a week for the entire household, because you can't ask one person to eat differently at the table when everybody else is eating poorly. That stands to reason. The program involved nutritional counseling, care coordination, and clinical monitoring wrapped around the food support with biometric outcomes, HbA1c, weight, blood pressure, cholesterol, on track closely as any other drug trial. The utilization numbers is where this stops being a feel-good story and becomes a balance street story. 75% fewer hospital admissions, 30% fewer emergency room visits, and potential savings of $16,000 to $24,000 per patient associated with every 2-point reduction in HbA1c, and a 40% decrease in the risk of death or serious complications. So this is what happens when you treat the actual cause of the disease rather than just managing its downstream consequences indefinitely. Type 2 diabetes is, in a large portion of cases, a disease of poverty and food environment, not a personal failure willpower. Geisinger stopped treating it like one. Another example is Boston Medical Center. They have a comprehensive food infrastructure. And Boston Medical Center was the first hospital in the country to build a comprehensive food as medicine program at scale, launching it in 2001, decades before the rest of us even became aware of this. Today, they distribute more than 1 million pounds of food annually and have served more than 1 million people since the program began. More than 50,000 pounds a month reaching upwards of 1,800 families, roughly 7,000 people every month, and 40% are children. The model has three components, and the integration across them, that's the point. First, a preventive food pantry stocked with medically appropriate food, aligned to specific chronic conditions, and available to patients and their families without the usual bureaucratic friction of most food assistance programs. Second, a rooftop farm that produces fresh produce for the pantry and for the hospital's food service. And third, a teaching kitchen where patients learn to prepare the food they're receiving in ways that are culturally relevant and practically sustainable at home. The third piece, matters more than it seems, because it's not enough to hand someone a bag of produce. If they don't know how to prepare it in a way that tastes good to their family, bag goes bad in the refrigerator. Well, the teaching kitchen, it closes the loop between a clinical prescription and the behavior change. Patient satisfaction with the pantry is run above 90% in annual surveys, a number most hospital services would envy. But BMC didn't stop at food. The medical legal partnership embeds attorneys alongside clinicians to resolve housing, utility, and benefits problems that no prescription can begin to touch. Their street cred program has returned more than 8.3 million to upward of 2,700 families since 2016 through tax assistance, putting money directly back into household budgets that are often 1 month from experiencing a health crisis. The Elders Living at Home program helps high-risk seniors stay safely housed. And none of this is a generic food bank bolted onto a hospital. It's a clinical supply chain organized around diagnosable, treatable conditions for which food, housing stability, financial security are all primary interventions. BMC built this because the data told them food insecurity was showing up in the ER and driving preventable hospitalizations. They decided to address the cause, and we'll come back to a second piece of the strategy in a second, the one involving housing in the next episode. And the third example is Cleveland Clinic and their shared medical appointments and lifestyle medicine. Cleveland Clinic approached the food and lifestyle question from a different angle. Through the clinical encounter itself, their approach uses shared medical appointments to deliver nutrition and lifestyle interventions at a scale that individual appointments simply can't achieve. Here's the model. Instead of one patient seeing one physician for 15 minutes, a small group of patients with similar conditions meets together with a multidisciplinary team, physician, nutritionist, health coach, behavioral health specialist. The session covers exercise and movement, sleep, stress, resilience, social relationships, and of course, nutrition. The efficiency is obvious. You can reach more patients per clinical hour. But the therapeutic effect is even more interesting and compelling. Patients hearing from peers who share their diagnosis, their struggles, and their progress turns out to be clinically significant. Social reinforcement, shared accountability, and the normalization of lifestyle change all happen in the room. The group becomes part of the intervention. So Cleveland Clinic's results with lifestyle-based interventions, particularly for type 2 diabetes, cardiovascular disease, and metabolic conditions, demonstrate what happens when you treat the underlying drivers of chronic disease rather than just managing the downstream systems. Weight comes down, medications get reduced, hospitalizations decline. This is lifestyle medicine. Evidence-based interventions organized around the things that actually cause most of what's killing us. And it requires a payment model that rewards these outcomes which is exactly what episode was about. So let me close with observation. 3 organizations, 3 models. 1 conclusion: food is medicine, and the industry's continued reluctance to treat it that way is costing money and lives at the same time. Now, Geisler's numbers aren't outliers. They've been replicated enough across programs that continued skepticism isn't a scientific position. It's a financial preference, a preference continuing to pay for the consequence of food insecurity rather than addressing food insecurity itself. So to every health plan, every board member listening, the question isn't whether food interventions work. That question's been answered. The question is whether your plan is going to fund them and at scale required to move the needle. Not as a pilot, not as a community benefit add-on, but as a core clinical strategy. So in the next episode, we're going to go upstream even further. We're going to talk about housing and what happens when hospitals start waiting for somebody else to solve them. Well, thank you for joining me in More Health, Less Healthcare. And next episode, we'll look directly at housing. Thanks.